to severe rheumatoid arthritis, treatment of children with polyarticular or systemic idiopathic arthritis, giant cell arteritis, and diffuse large B-cell lymphoma and acute lymphoblastic leukemia patients with CAR T therapy-induced cytokine release syndrome. This diagram depicts the action of tocilizumab or Actemra in inhibiting soluble and membrane-bound IL-6 receptors, leading to IL-6 signaling inhibition, which leads to, among other effects, reduced systemic inflammation. In terms of the hypothesis for effectiveness in COVID-19, we know that patients with COVID-19 have increased levels of inflammatory markers, including IL-1, IL-6, TNF-alpha, D-dimers, ferritin, and CRP. And this excessive inflammatory response can result in lung injury, including diffuse alveolar inflammation, neutrophilic infiltrates, and microvascular thrombosis. The beneficial effects of dexamethasone in COVID-19 patients with hypoxic respiratory failure suggested that the additional benefit may be achieved through inhibition of more specific immunomodulatory targets, such as IL-6. This is a summary slide of the randomized control trials conducted to date, comparing tocilizumab to placebo or to standard of care in the treatment of patients with COVID-19. Over time, you can see that trials included more patients on invasive mechanical ventilation and had increased concomitant corticosteroid use. Today, we're going to be reviewing the two bolded landmark trials, REMAP-CAP and Recovery, which are the last two trials listed on this slide. REMAP-CAP is the first of the two trials that we'll review today. This study was a randomized, multi-centered, multi-platform adaptive trial conducted at 113 sites in 6 different countries listed here. Patients were enrolled between April and November 2020. The patients in this study were critically ill adults with COVID-19, either proven or suspected, within 24 hours of starting respiratory or cardiovascular support. Respiratory support was defined as invasive or non-invasive mechanical ventilation, including via high-flow nasal cannula if the flow was over 30 liters per minute and the FiO2 above 0.4. Cardiovascular support was defined as patients requiring either vasopressors or inotropes. The intervention in this study was tocilizumab at a dose of 8 milligrams per kilogram with a maximum dose of 800 milligrams, or sarilumab at a dose of 400 milligrams as compared to standard of care, which was the control group. Tocilizumab could be repeated 12 to 24 hours after the first dose if needed. In terms of outcomes for this trial, the primary endpoint was respiratory and cardiovascular organ support-free days up to day 21. This was a composite ordinal outcome. Deaths were assigned the worst outcome with a score of -1. And among survivors, respiratory and cardiovascular organ support-free days were calculated up to day 21, with a higher number meaning a faster recovery. So for example, a patient who died at day 18 would be assigned a -1 day score, and a patient who came off of organ support at day 15 would be assigned a 6-day score because they spent 6 days free of organ support. In terms of secondary outcomes, they included hospital mortality or survival, 90-day survival, time to ICU discharge, time to hospital discharge, WHO ordinal scale at day 14, with 0 meaning no illness, all the way up to 8, which was death. And finally, progression to invasive mechanical ventilation, ECMO, or death in patients who were not intubated at baseline. A total of 865 patients were enrolled in this trial. As you can see from this chart here, baseline characteristics were well matched between the tocilizumab and control groups. The average age was around 62 years. It included about 74% males, about 70% white race. The median patient was slightly obese at 30.5 BMI. The median Apache 2 score was 13. 35% of patients in the trial had diabetes, about 10% had kidney disease, 24% had respiratory disease, 10% had severe cardiovascular disease, The average time to enrollment from hospital admission was 1.2 days, and the average time to enrollment from ICU admission was 13 hours. About 29% of patients in this trial required high flow nasal cannula, 42% required non-invasive ventilation, and about 30% required invasive mechanical ventilation. 18% required vasopressor support. The median PF ratio in the trial at baseline was 115, corresponding to moderate ARDS. The median CRP was 150, and 88% of patients were receiving corticosteroids at enrollment or within 48 hours. With respect to the primary outcome in this trial, the tocilizumab group had a median of 10 organ support-free days as compared to 0 in the control group. Hospital mortality was also reduced with a 28% mortality in the tocilizumab group as compared to 36% in the control group. And of note, 29% of patients received a second dose of tocilizumab in this trial. Here are the results of the primary outcome depicted graphically. You can see that patients who received tocilizumab, which are reflected in the top bar, had a greater number of organ support-free days as compared to those in the control group, which is the bottom bar, as evidenced by a greater percentage of tocilizumab patients in the blue shades here and less in the red shades. With respect to secondary outcomes, tocilizumab treatment resulted in an improvement in 90-day survival, increased respiratory and cardiovascular support-free days, as well as decreased time to ICU discharge. The next trial I'll be discussing is the recovery trial. This was a randomized, multi-centered, open-label platform trial whose group published on dexamethasone last year. The randomization process was a little complex. The first randomization occurred on entry into the multi-platform trial. Patients could then be randomized into the tocilizumab versus standard of care trial within 21 days of that first randomization. On average, the tocilizumab randomization happened around 2 days after hospitalization. This trial was conducted at 131 sites in the UK. It was conducted between April 2020 and January of this year. Inclusion criteria included adults hospitalized with COVID-19 and both systemic inflammation as evidenced by a CRP of greater or equal to 75, as well as hypoxia with an O2 sat of less than 92% on room air or requiring oxygen therapy. Exclusion criteria included a known hypersensitivity to tocilizumab or evidence of active TB, bacterial, fungal, viral, or other infection. The intervention in this trial was weight-based dose-banded tocilizumab at a dose ranging from 400 to 800 milligrams, along with standard of care as compared to standard of care alone. The second dose could be repeated 12 to 24 hours later if no improvement, similar to what was done in the REMAP-CAP trial. In terms of outcomes in the recovery trial, the primary endpoint was 28-day mortality, and secondary outcomes included discharge alive from hospital within 28 days, and a composite of requirement for invasive mechanical ventilation, including ECMO, for patients not requiring these interventions at randomization, as well as death. The recovery trial included a total of 4,116 patients. As with the REMAP-CAP trial, baseline characteristics of the patient groups were well matched. Age, percentage male, and percentage white were similar to that seen in REMAP-CAP. In this trial, 28% of patients had diabetes, 23% had chronic lung disease, and 22% had heart disease. The patients were enrolled on average 9 days post-symptom onset and 2 days post-hospitalization. As compared to REMAP-CAP, which only enrolled ICU patients, recovery included 46% non-ventilated patients, with the vast majority requiring oxygen therapy, and 41% of patients who were receiving non-invasive ventilation, as well as 13% of patients who were mechanically ventilated. CRP values were similar to that seen in REMAP-CAP. Steroid use was somewhat lower at 82% at the time of enrollment or within 48 hours. And 27% of patients received remdesivir, which has demonstrated benefit in the moderately ill COVID population. In terms of the primary outcome of 28-day mortality, recovery found a 14% relative risk reduction and a 4% absolute risk reduction in patients receiving tocilizumab as compared to usual care. With respect to secondary outcomes, the study found that patients randomized to tocilizumab had an increased likelihood of discharge alive from hospital within 28 days, as well as a reduction in the requirement for mechanical ventilation. Of note, 17% of patients randomized to tocilizumab did not actually receive tocilizumab, so results may therefore underestimate the true treatment effect in this intention to treat analysis. Similar to REMAP-CAP, 29% of patients received 2 doses of tocilizumab. Here is the Kaplan-Meier curve for the primary outcome of 28-day mortality with tocilizumab in red and usual care in black. As you can see, patients on tocilizumab had a reduced mortality as compared to patients who received usual care, with curve separation occurring approximately 1 week post-randomization. In terms of pre-specified analyses of the primary outcome, these were performed in subgroups defined by 6 characteristics at the time of randomization, including age, sex, ethnicity, days since symptom onset, degree of respiratory support at randomization, and use of systemic corticosteroids, including dexamethasone. As you can see, males, white race, fewer days since symptom onset, and corticosteroid use appear to benefit more than comparator groups in these subgroup analyses. However, these results were thought to be more likely due to the play of chance, and we have not been able to establish a particular subgroup that may derive a greater comparative benefit from this therapy. With that, I will hand it over to my colleague, Dr. Munshi, who will discuss placing this research into context and our guideline recommendations.
Thanks so much, Stephanie. And thanks everyone for joining us this afternoon. So to frame our recommendations, our group reviewed the results of the 9 RCTs available at the time of publication of our science brief, which was February 20th, that compared tocilizumab to placebo or standard of care at that time. And that ended up including approximately 6,000 patients with COVID that were hospitalized. So as you can see here on this forest plot, when we combine all studies in this meta-analysis, tocilizumab reduced mortality, and this was largely, not surprisingly, driven by the 2 largest trials, Recovery and REMAP-CAP. And when you look at this forest plot, you may note that the smaller trials are not individually statistically significant. There's large confidence intervals, and this could be explained by multiple factors, including differences in severity of illness, some being stopped early and potentially underpowered. Some did not focus on sicker patients or those that were enriched by inflammatory markers in the setting of moderate disease. And many of the trials that did not find benefit did not use corticosteroids as the standard of care in the majority of their patients. For the subset of trials that looked at critically ill patients and were negative, tocilizumab was also given at a relatively later time in their course of critical illness. So going back to REMAP-CAP and Recovery, as Stephanie had mentioned, 80% corticosteroid use. And in the REMAP-CAP cohort of the critically ill patients, the majority of those actually received tocilizumab fairly early after the onset of critical illness. So the next analysis is the pooled results looking at the need for invasive mechanical ventilation. And when we do pool the results of all the trials, it basically showed that it was successful in reducing those requiring mechanical ventilation. Now, the next forest plot basically shows that a subset of patients might not have received mechanical ventilation because of sudden deterioration or death. Therefore, when we pooled the composite outcome of death or mechanical ventilation, it was also found to reduce that composite outcome. Finally, in our final forest plot, we're going to hear more information from Beth about adverse events in these trials, but these studies rarely reported major adverse events associated with tocilizumab, and they were no more likely to experience these serious adverse events than patients in the placebo group, and this might have included infection, neutropenia, thrombocytopenia, or hepatotoxicity. That being said, recovery looked at cause-specific mortality, and infections were not increased when it came to cause-specific mortality, but infections alone were not specifically reported in the recovery trial. So in the next slide, I just wanted to highlight a review that's going to be published tomorrow that was led by a few intensivists in Toronto, Federico Angerman, Bruno Ferrero, and Lorenzo Del Sorbo. And it really tries to take and synthesize the evidence to date and put the research into context. And I just wanted to highlight one figure that was created by Federico and Bruno that nicely provides a snapshot of the state of the evidence overlying the pathophysiologic process that is likely underlying the development of ARDS in the setting of COVID-19. So there's two important time intervals. There's time from symptom onset and there's time to deterioration. And as you can see in the curves at the bottom, viral replication, as you know, often peaks earlier, and then that's followed by a progressive rise in the inflammatory cascade. And this is likely where TOCI is most effective and can have an impact on organ failure and mortality and morbidity. However, there's also likely a critical tipping point where that inflammatory cascade tips into a state of hyperinflammation, which is probably a little later in critical illness, where it may be too late for TOCI to take effect. So therefore, it's hypothesized that any benefit in targeting the inflammatory response may have a certain time window, which is likely the slope of this red line, where IL-6 inhibitors are probably most beneficial and organ dysfunction may be most likely to be reversed. So recovery seems to target the progressive inflammatory patient, likely on the climb of this inflammatory red curve. And REMAP-CAP seemed to also have isolated a more critical subset towards the peak of this inflammatory curve and in that 24-hour time window that was captured pre-hyperinflammation. So moving on to the recommendations, and this was without considering some supply limitations. So in the critical care cohort, we recommended that tocilizumab be given for critically ill patients that are also receiving dexamethasone therapy or dose equivalent corticosteroids and are within 14 days of hospital admission, because the ARDS can really develop at any point within those 14 days. And the etiology of deterioration and progression to ARDS needs to be temporally associated with COVID-19. Critically ill is defined as patients requiring high flow nasal cannula or non-invasive or invasive mechanical ventilation. And CRP criteria is not needed because in the REMAP-CAP trial, there was really no differential treatment effect across high or low CRPs or for patients requiring circulatory support. And according to the recovery and REMAP-CAP trials, the second dose could be considered after 24 hours if the patient is not improving. But I do want to add that many believe that it is most effective within the 24-hour time period within the development of critical illness, as was demonstrated in REMAP-CAP, which showed statistically significant results, which might have not been seen in the other critical care studies looking at TOCI, where it was administered a little later. For the moderately ill patients, TOCI is recommended for patients who are hypoxemic with evidence of systemic inflammation and evidence of disease progression after 24 hours of dexamethasone therapy and are within 14 days of hospital admission or within 14 days if it was nosocomially acquired. And finally, in mildly ill patients at this point, tocilizumab is not recommended for this population outside of clinical trials. There are some practical considerations and exclusions, such as greater than 14 days after hospital admission or diagnosis if it's nosocomially acquired, any previous intolerance to TOCI, or any concomitant bacterial, fungal, viral, or other infectious processes. And patients should probably be monitored for potential complications, which we'll hear a little bit more about in the last part of this presentation. So with regard to dosing, the two largest trials, REMAP-CAP and recovery, had two different approaches to dosing. In REMAP-CAP, IV tocilizumab was either determined by an 8 milligram per kilogram dose up to 800 milligrams, or according to recovery, it was weight-based band dosing strategies outlined below. So in summary, when we look at the recommendations, we would recommend tocilizumab associated with dexamethasone therapy in patients who are admitted to hospital within 14 days. In moderately ill patients, it should be considered in patients who require supplemental oxygen therapy but have some inflammatory parameters defined by the CRP greater than 75 and are deteriorating after 24 hours of dexamethasone therapy. And currently, we're not recommending it in the mildly ill population. And with that, I will turn it over to Beth for the final portion of her presentation.
Thanks, Laveena. So I'm just going to talk a little bit about secondary infections, and then I'll spend the last part of this presentation talking a little bit about the drug shortage and the kind of issues accessing tocilizumab, which led to our most recent science brief. So in terms of contraindications, I want to note that the contraindications listed in the product monograph may not apply in patients with COVID. And as you can see here, patients with active infections is actually a contraindication, but of course we know this is beneficial as you've seen the data presented by Stephanie and Laveena. So next, Brad. There is, though, also a black box warning for risk of serious infections. And it's important to note that tocilizumab, for its approved indications, is usually used as a chronic therapy, so many doses over a long period of time. And in the case of COVID, we are giving 1 or 2 doses, but we are also giving corticosteroids on top. So you can see that there's a variety of infections that have been reported from opportunistic infections to other bacterial infections as well. Next. So I just wanted to take a quick look at the randomized controlled trials that were reviewed earlier and just take a quick peek at what they observed. There is a lot of information on this slide, but these slides will be posted afterwards. And I just want to point out a couple things. Next. So in terms of infections in these trials, and again, the numbers are small, but they did not see an increased number of infections with tocilizumab group. In fact, a lot of times the absolute number was smaller and the rates were somewhat smaller. So if you look at the Back Bay trial, there was 8% of serious infections, where the standard arm had 17%. And in Covacta, there were around the same rate of serious events. So in the tocilizumab group, you can see it's 23.7, and the standard of care, it was 29, but they included COVID-related deaths as a part of serious infections. So there is a little bit of heterogeneity here in terms of how people defined infections, and some people were very specific, and some people didn't really expand too much on what these infections actually were. Next. But what is clear also is that the neutropenia or lymphopenia, which is an expected side effect of tocilizumab, was clearly more significant. And in terms of absolute numbers, you can see that the standard of care rarely had serious neutropenia, whereas the tocilizumab group clearly did. Next. And here's the next set of studies from the previous randomized controlled trials that were reviewed. And you can see, I guess, like a similar pattern here as well. Next. With the infections being somewhat similar between the groups, some trials reporting a lot more granular details about their infections and some trials not. Next. But again, the neutropenia you can see was definitely more common. The other thing I wanted to point out is, sorry, thanks. The other thing I just want to point out before we move on is that the average follow-up in these studies ranged somewhere from 14 to 21 days. A couple studies had their safety follow-up later, so 60 days. And some people, such as REMAP-CAP, they didn't actually define whether they extended their safety monitoring. And recovery, one of our largest trials, which is still in preprint, their outcomes are at 28 days, but I think this has been a common comment on the recovery trial is because of the way that they rolled it out so quickly, their data gathering for adverse effects is not as granular as a lot of the other trials. So actually they don't really describe very much about their infection. And they had just had one line that probably because you're using this earlier in COVID and complicating bacterial infections are infrequent in early COVID, that is probably okay, but I don't know that we can for sure say that. Next. So I wanna next just show this nice living review that Brad actually and members of the Toronto Antimicrobial Resistance Research Network did, where they showed nicely that it is true in early initial presentation of COVID, co-infection is very low, so around 3.5%, and going up to somewhere around 14 later in presentation. But as you can see, there's a mismatch here because we have over 70% of cases who have antibiotic prescribing. So this is a great opportunity for antimicrobial stewardship. Next. So in terms of secondary infections, bacterial co-infection is pretty uncommon. And so upon initial presentation, probably concomitant antibiotic therapy is not necessary, even if the patient is going to be getting tocilizumab, where we have a concern about secondary infections. Of note, recovery did exclude patients with active infections, and they didn't really specify how that was done. But certainly I know some centers, if you are on empiric antibiotics, you may not get tocilizumab. So you'll stop the antibiotics and give the tocilizumab because it's more likely they're COVID. They probably need the tocilizumab more. In terms of other infections, so there's a risk of strongyloides, and we're working on a brief right now, so stay tuned. But there's a common question, should we give ivermectin to treat strongyloidiasis? And one important thing to point out is that the risk of strongyloidiasis parasitic infection is based on both geographic and clinical risk factors. And really the geographic risk factors are if the patient is born or has extended exposure, defined as a cumulative 6-month exposure in rural or beach areas, or contact of the skin with sand or soil in a risk area, even if it's shorter term travel, there is a risk that they could have strongyloidiasis. And often it's asymptomatic. So we are making recommendations about screening, potentially, whether and how to send serologies and whether you need to empirically treat with ivermectin before the serology comes back. It's the best evidence with strongyloidiasis risk is actually with corticosteroids, where there are CATMAT guidelines that talk about a certain threshold of steroids where you probably should screen and consider ivermectin. But the problem is that monotherapy tocilizumab risk is not well described. Prior to COVID, we weren't broadly using tocilizumab in a lot of the population. It was for these specific disease states. So the other question is, if you're giving both tocilizumab and steroids, does that increase your risk? So we're working on this. Stay tuned for more details. But we want to also mention that ivermectin is a drug that is also currently on shortage, and we are not recommending it for prophylaxis or treatment of COVID itself, which is something that there have been some preprints and advocates of using ivermectin, but at this time we are not recommending it for treatment of COVID. In terms of other infections, we need more follow-up data to describe infection risk, and so that would include late bacterial co-infections, other opportunistic infections, which there have now been case reports of, such as aspergillosis and pneumocystis. Next. So I just want to quickly talk about, thank you so much for Fahad, Razak, and Amol Verma from Gemini for sharing their data with us. This will be, this is in press with CMAG, but knowing all of this and knowing that tocilizumab is on shortage, we wanted to look at projections of how much tocilizumab do we think that we might need to use, especially in this third wave that we're in now, where we know case numbers are going up. So they used their Gemini data to look at adult hospitalizations for COVID at 6 hospitals in the GTA, and they applied the eligibility criteria from either recovery or REMAP-CAB. Next. And they estimated that about 42% of adults hospitalized with COVID-19 would be eligible for tocilizumab. And so taking into account if the third wave of the pandemic is at least as severe as the second wave, then approximately 7,500 COVID hospitalizations might be expected, and therefore more than 3,000 patients could be eligible for tocilizumab just in Ontario. Next. And of course, we know that cases are rapidly increasing in most public health units. This is from the science table modeling from April 16th, but I'm sure you can imagine that these numbers are worse by now. Next. So the science table did a survey in late March, knowing that tocilizumab is known to be in short supply globally. Of course, many people are wanting to use it for treatment of COVID. Currently, it's being managed by the Canadian Pharmaceutical Distribution Network, CPDN, which is in charge of allocating and distributing tocilizumab across and within provinces in Canada. So the supply for other indications, such as CRT, CAR T therapy, is sequestered, and there's a separate supply that is earmarked for COVID use. So we did a survey in March. I'm not going to go into a lot of detail here about the details of it. You can read more about it in our science brief, but I did want to show some of the findings here, which is that at the time of the survey, hospitals who did have allocations didn't necessarily match up where tocilizumab may have been needed. So you can see here, all the blue dots are hospitals which did not have an allocation of tocilizumab to their hospital, and the green dots are where tocilizumab was allocated to a hospital. And you can see the first picture that was up was from March, and we repeated this with the recent case numbers from PHO, and you can see that, of course, there's more cases, and there's a lot of areas where hospitals do not have allocation of tocilizumab, but may have very high case rate changes. Next. And here's just a zoomed in picture of the same information. So you can see that there's a little bit of an unequal distribution here at the time of the survey. And actually, I'll use this opportunity to quickly plug that we've done the survey again. We just sent it out at the end of last week. So if you're on this call and you received the survey, we'd really appreciate it if you could fill it out and let us know what your experience with tocilizumab utilization and your allocations are. Okay, next. So I'm gonna end by talking a little bit about strategies to manage tocilizumab supply. So as mentioned, the Science Advisory Table was aware of the tocilizumab shortage. And after conducting this survey in late March, we did recommend that if Ontario enters a shortage of tocilizumab situation, it will need to consider approaches that optimize the effectiveness and the equity of the current supply. So working with the Ontario COVID-19 Bioethics Table Framework, we released a science brief providing recommendations and options for each stage. And you can see here, stage 1 is preserving the standard of care for as many COVID-19 patients as possible by conserving supply, sharing supply, and procuring and accessing new supply. Stage 2 is to optimize therapeutic benefit based on existing evidence within the available supply. And stage 3 is to use a fair procedure to choose between patients if stage 1 and 2 are insufficient to meet the demand. Next. So going back to our revised recommendations, these were updated on April 6th, then the full brief was released, I think, on April 18th. Next. So tocilizumab dosing recommendations in stage 2 are that the dose should be reduced to 400 milligrams. Second doses are not recommended. And based on the data that Laveena and Stephanie showed you, it's not recommended to triage patients based on factors demonstrating which patients are most likely to benefit, because there hasn't been a specific subpopulation in the literature that is shown to benefit more than another. Next. And so the current state as of April 18th is that the Ontario Critical Care COVID-19 Command Center has taken over kind of the support, oversight, and accountability for the distribution of tocilizumab. And they will receive guidance from the science table and take that into consideration. And the lead at the Ministry of Health, and Jin, the senior director at UHN, and who's the lead for the ICU Medication Task Force, are going to help operationalize this. So thank you. So the conclusions are that tocilizumab can blunt the inflammatory cascade associated with COVID-19. The effect of tocilizumab is consistent across subgroups of moderately ill patients with evidence of systemic inflammation or critically ill patients. In our pooled meta-analysis, there was evidence of a mortality benefit, and these results were largely driven by recovery trial, which included dexamethasone as a standard of care. And more data is needed to quantify the infection risk, the optimal dosing, and whether the results are generalizable to other IL-6 receptor antagonists. So we'd just like to also have acknowledgements here to the co-leads of the Drugs and Biologics Clinical Practice Guidelines Work Group. And thank you for Drs. Fahad Razak and Amol Verma for sharing their information, which is soon to come to print with us just for the purpose of this webinar. I'll turn it back to you, Brad.
Great, thank you so much, everybody. Thanks, thanks, Drs. Carlin, Munshi, and Leung for your excellent presentation. I think it's been very detailed and lots of information to pack into such a short period of time. So we do have some time for questions, and if you do have any questions, please enter them into the chat box. I can start with some that are already here. So somebody has mentioned, Iona Buddha has mentioned that NIH recommends, as of March 5th, that recently hospitalized patients within the first 3 days of admission, giving tocilizumab and ivermectin in terms of prophylactic treatment for strongyloides in patients who are from endemic areas. So as I think as Beth mentioned, that's something that's in the works from our end in Ontario, that we may have some similar recommendations, but I don't know if you wanted to add anything further to that, Beth.
Oh, hi, Brad. Yeah, so I think if we didn't have a shortage of ivermectin, that might be one strategy where you wouldn't miss patients per se who would be high risk to develop disseminated strongyloidiasis with immunosuppression. I guess the problem is that ivermectin in Canada is on shortage until December at least. And so we do have CATMAT guidelines that I mentioned before, which stratify people into low, moderate, and high risk in terms of geographic areas. And that has implications on whether you would choose to empirically treat with ivermectin, or whether you would take a test and treat approach and test first with the serology and only treat if it comes back positive. So we're working right now on a brief that is going to balance those two things, given our very limited ivermectin supply. And of course, ivermectin is a necessary drug to treat severe parasitic infections. So if people do develop hyperinfection because they've received immunosuppression and they've had, let's say, like latent strongyloides, they've had asymptomatic strongyloides, which gets disseminated because you've immunosuppressed the patient. Those patients need longer courses of ivermectin and potentially additional antiparasitic agents. So we do want to make sure that we have ivermectin for people who actually do have the parasitic infection. But yes, I agree that, you know, if we didn't have a shortage, we probably, it might be a safer approach to give it to everybody up front. And in that way, if you were going to be doing that, you may not have to do as much testing. But again, we're trying to balance those two things, so stay tuned for an update.
Great, thank you, Beth. The next question is from Claudio Martin. Can you discuss the rationale for the lower dose of tocilizumab? There's really, not much evidence for it. And they say no evidence for a cohort that benefits from that specific dose. So would anybody want to take a stab at that question in terms of the 400 milligrams fixed dosing?
Sure, I can take that one.
Go ahead, Steph.
Oh, okay. So in terms of this, obviously, if there weren't the supply issues with tocilizumab, we would want to recommend the evidence-based dosing. So it really is in the context of shortages that we've recommended this reduced dose of 400 milligrams. Having said that, we had reached out to the authors of the landmark trials investigating tocilizumab in COVID-19 patients and sort of asked where did their dosing come from. And essentially it was extrapolated from the rheumatoid arthritis and CAR-T literature where this type of dosing was used. So it wasn't specifically designed to be used for COVID-19 at those doses. And we also know that IL-6 levels tend to be lower in patients with COVID-19. So it's thought that they may not require the same types of doses that are required for the treatment of things like rheumatoid arthritis and for cytokine release syndrome. So again, not great evidence. It's kind of, extrapolated from other things and PK data. And again, we would want to use the higher evidence-based dosing and would recommend such if we had adequate supply, but it's really just in the context of this shortage that we've recommended the lower dosing.
And maybe if I can add, Stephanie, sorry if you already mentioned this as well. I guess there's some kind of preliminary data that also demonstrates that IL-6 receptors are maximally saturated at much lower doses than 8 milligrams per kilogram, or even 4 milligrams per kilogram, which is around the 400 milligram dosing mark. So for kind of the reasons that Stephanie mentioned, and some preliminary data that shows that 8 milligrams per kilogram is likely a much higher dose than what's needed, and you can maximally saturate it in much lower doses. That was just part of the rationale in the setting of supply limitations.
Thank you both. And a follow-up to that, in terms of the 4 milligram fixed dosing, is there any benefit in terms of focusing on a specific patient population that might benefit the most using a regular 8 milligram per kilogram dosing rather than fixed dosing for all that meet the eligibility criteria? For example, selecting only critically ill patients to receive the standard dose. What are your thoughts on that?
I'll just give my preliminary thoughts. When we talked about it, when we looked at the evidence and we looked at the subgroups, we couldn't really tease out clinical characteristics or a specific subset that we could kind of justify variability across the dosing, or giving Toci versus not giving Toci for. And as Stephanie mentioned, some of the members of our group went back to some of the original authors, and similarly, we couldn't, they didn't have data to share with us to help us more precisely allocate it to a subset of patients that may derive a greater benefit. Maybe with more time and more data coming out, we'll be able to be more precise about the subgroups that develop benefit, but with the data that we have to date, we couldn't tease out a specific subgroup. But that's an excellent question, and hopefully with more data, we'll have more insight on how to better allocate.
Thank you. A question from Dr. Kevin Goff. The current guidelines suggest that Toci is used for moderately ill patients if there's progression despite 24 to 48 hours of dexamethasone therapy. So do the data support this specific timeline, or could an opportunity be missed? I guess the question is, should we be giving Toci earlier and not waiting 24 to 48 hours for progression on dexamethasone?
Okay, I can take this one. So just to clarify, in terms of the critically ill, we do recommend administering tocilizumab upfront at the same time as the steroids, because that's what was done in REMAP-CAP. But in the moderately ill patients, as per recovery, we do recommend administering steroids first and only initiating Toci 24 to 48 hours later with progressive disease and with a CRP above 75, because that was what was done in the recovery trial. We also feel that it's a beneficial approach from a stewardship perspective, because we know that given, again, the shortages of this medication, otherwise we would be administering it to all hypoxic patients admitted to hospital, which would end up being a really large number of patients.
Thank you, Stephanie. The next question is about, I guess none of us have a crystal ball here, but the prediction as to when we may need, or if we may need to move to a stage 3 in terms of tocilizumab rationing. What are your thoughts on that?
I guess I can take a stab at this first, and maybe Laveena and Stephanie can chime in if they have additional thoughts. Yeah, I mean, this is really difficult. The Health Canada has been working with the manufacturer in order to try to obtain additional supply, but it's not stabilized. So, every couple of weeks we learn that, we might get another shipment. I think the purpose also of stage 2 is to hope that we never get to stage 3. But now that the command table, as I mentioned, as of April 18th, is taking over the monitoring and accountability for the supply. They do have a pulse on what the provincial supply looks like. I did hear that hopefully we may be getting some more next week. So that's good news. But yeah, I hope that we won't have to move to stage 3. I think most of our stage 2 recommendations with this fixed dose, which is not evidence supported, but has some rationale behind it, is to avoid us to move to that stage.
Next question is about the use of tocilizumab in pediatric patients. I know we're mostly adult practitioners here, but what are your opinions on the use of tocilizumab in that patient population, knowing that most of the trials enrolled adult patients and pediatric patients may present differently in terms of being, in terms of the level of severity required to meet the eligibility criteria. So any thoughts on TOCI in pediatric populations?
Yeah, I can take this because Melanie Sung and Anu, who are part of our working group, I just asked them this the other day because of the issues about tocilizumab supply, and most of it has been, as you know, like the trials are in adults. So it sounds like right now it's a case-by-case discussion. It sounds like in pediatrics, they may have more comfort with using anakinra, which is another immunomodulatory agent in other types of disease states in pediatrics. And the MsCI is also something where anakinra has been suggested to be beneficial. So as of a couple of weeks ago, it sounded like at least locally, no one had been used tocilizumab, and it would be a case-by-case discussion as to what immunomodulatory therapy would be the most appropriate for that specific patient. But I think they are also, the trials are in adults, so there's more comfort with using anakinra, which has been used more in pediatrics.
Mm-hmm. Thanks so much for that. Another question from Christina Kozlowski. What are your thoughts on using a higher dexamethasone dose in lieu of tocilizumab in patients who are worsening, given the context of the shortage that we're in?
I can maybe start with this one. I think that's an excellent question. It's a question that my OC group kind of just as well. And I think the short answer is we really just don't have enough data to inform this strategy. But I mean, mechanistically, I can see why it makes sense. And there are actually ongoing studies looking exactly at that question. What I know some of my colleagues have done, if a patient has had, seeming contraindication to tocilizumab, such as LFTs that are elevated, in that circumstance, if they're not going to be giving their patient tocilizumab if they're eligible, we tend to then use the DEXA ARDS steroid regimen, which is dexamethasone 20 for 5 days and then 10 milligrams for 5 days, which was informed from a trial that was published just before the pandemic. So, sometimes we do that as an alternative, but excellent question. And I think we're kind of looking forward to data to come out to inform us better on that specific question.
Thank you, Laveena. Question from Philip George. Why are we not including CRP criteria, which is greater than 75 in those who are critically ill, just like those in the moderately ill patient population?
So I can take that one maybe as well as a first step. So as you know, recovery CRP, and we think that's certainly useful to kind of select the more inflammatory subset. REMAP CAP, however, which only included critically ill patients, there actually was no difference in outcome based upon CRP thresholds. And to me, that this basically suggests that when patients become critically ill, commonly used inflammatory markers such as CRP may not be sensitive enough to adequately select patients that may benefit, since their biological associations with IL-6 or CRP may not be linear. And a recent systematic review and meta-analysis of critically ill patients showed that IL-6 levels were not significantly higher in patients with in critically ill subset compared to those with less severe disease. So we don't really know if IL-6 or CRP are predictors or effectors or both of clinical deterioration. which is why we kind of stuck with REMAP CAP entry criteria for the recommendation for the critically ill subset.
Just a reminder, if anybody has their microphones on, please turn them off because there's a little bit of feedback. A question from Megan Riordan. Can you discuss tocilizumab in a patient with transaminitis or a history of hepatitis?
I can take this one. So as you may be aware, there is a black box warning for tocilizumab to avoid in active liver disease or hepatic impairment with liver enzymes above 3 times the upper limit of normal. Obviously, as you guys are all likely aware, we often see some rise in liver enzymes in our COVID patients, whether that's due to hepatic inflammation, hypoxia, or other factors. So, I think it's not unreasonable to allow for some elevation in liver enzymes before giving tocilizumab. Just in terms of the trial data, REMAP CAP excluded patients with AST or ALT above 5 times the upper limit of normal. Recovery didn't specifically specify or exclude patients based on these parameters. So I think probably best practice would be to check LFTs before administration of TOCI to ensure that they are not more than 3 to 5 times the upper limit of normal. And just to have a low threshold to recheck if you're adding another hepatotoxic medication, or if the patient develops signs or symptoms of acute liver injury, probably within a month's time, because we know the half-life of tocilizumab is around 7 to 11 days after receiving the type of dose that we would be giving in the COVID-19 patients.
Great, thank you, Stephanie. Can anybody comment a little bit on sarilumab? There's a question here about equivalency between sarilumab and TOCI in terms of milligram to milligram. Is there any way we can do that kind of conversion? And the question is that would be reassuring because Sari is a fixed dose, whereas tocilizumab is not a fixed dose in most of the COVID-19 trials. So any comments on the use of Sari as an alternative?
Yeah, I can take this one. We are also working on a science brief about sarilumab currently. We're just waiting for the final data, which presumably will be a preprint from REMAP CAP. So on April 10th, they released a press release that they had completed enrollment in their immunomodulator arm. And so they had more than 900 participants additionally added to that arm, which includes anakinra, interferons, tocilizumab, and sarilumab. So I think we will get more data. Their press release mentioned that they met the pre-specified trigger for equivalence, which would be great news, and it would help us extend our supply if we could say that clinically sarilumab at a fixed dose of 400 is equivalent to the weight-banded dose of tocilizumab. That would be really helpful, of course. So stay tuned for that. We're hoping it will be released shortly.
Great. Thank you, Beth. I think we have time for one additional question. So there's a question here again from Claudio, who's previously asked some questions, but I think this is a good one in terms of how do we know if this policy decision to use a fixed dose actually had an impact. So any thoughts on ways of evaluating this to know that it's been effective?
So I think the honest answer is that we really don't know at this time. So we're making this recommendation again in light of the current shortages and sort of based on data that the dosing that was used in the trials for COVID-19 was only extrapolated from other indications. So again, not specifically tailored to COVID-19 treatment. And again, we know lower levels of medication are likely required to inhibit IL-6, which is present in smaller amounts in COVID-19 patients as compared to these other patient populations. So again, I think, again, honestly, we don't know for sure, but based on the data that we do have, we are sort of really confident in making this recommendation in the context of this shortage.
Yeah, and I'll just add that in the science brief, one thing that we included in terms of the rationing tocilizumab in a shortage was that we should study this because we're clearly doing something that's not specifically supported right now by clinical evidence. And extrapolation of biomarkers we know is not perfect. For example, their IL-6 levels actually go up, but they have clinical response. So, just targeting one specific biomarker out of many in the inflammatory cascade, it's actually still unclear whether we should be looking specifically at IL-6 or at other biomarkers in terms of predicting clinical response. So, but we have recommended, and again, the science table, we're basing everything on evidence and best practice. So we have recommended that in the shortage situation where we use a fixed dose, that we try to study it. And that may be where, databases like Fahad and Amol's database and other people who have real-time data may be able to look at this.
Great. Thank you, everyone. Thank you, Beth, Stephanie, and Laveena for your excellent work and sharing all of your insights with us. Just wanted to thank you guys for your presentation, and everyone who's on the line who's been listening. We had a great turnout, maxed out at 300 participants. And so for those of you who couldn't, those of the participants who couldn't make it, we will post this on the YouTube channel for the science table later on. So it will be recorded, and you can watch it at a later time. Just wanted to also say thank you to everyone because this is a very trying time for all of us, and we appreciate all of the work that everyone's been doing to care for our patients with COVID-19. So thank you for joining us, and have a good day.